Good morning, class.
Good morning, sir.
I hope
So, good
everyone
morning, everyone. We are fine.
is thank God. How was the week?
It's great. Fine.
Okay.
Okay, we thank God.
Oh, it was fine.
So
Okay.
please have your entry.
You managed it. It was okay.
We thank God.
Any concerns from last week lecture? Does anybody have a concern from last week lecture so that we can address it and then we'll move on to this lecture?
Sir, please come again.
I'm asking whether there's any question regarding last week lecture.
Oh, okay.
Yes. If there's no question, then we'll continue with today's lecture, right?
Yes, sir.
All right.
Yes.
Okay. So unfortunately where I am today, my network might not be all that stable. So once in a while it will go off and come, but bear with me. I'm trying to secure a very good network. And if along the lecture you can't hear me because of breakages, please do let me know. I also know the network sometimes fast track my speeches because of the logging of the internet. So if that happens, let me know. Looking at the feeding practices of these children. Today, we want to look at some challenges that comes with growth and development in these children, and some negative effect that may arise due to inappropriate feeding practices. So those challenges or work problems are what we call behavioral problems. So today we'll basically spend our time looking at behavioral problems of the child. Then after we are done looking at that, we'll go ahead to look at the IMCI, the Integrated Child Disease Management or Integrated Management of Childhood Illnesses, IMCI, which was a concept introduced somewhere in 2005 to enhance a standardized protocol for management of childhood diseases at the community level. So we'll go to look at the introduction, the concept of that, and see how far we will go with that. Hopefully, if we are able to finish that aspect, then we'll be in good business so that next week we can look at some common childhood diseases, okay? And then if we are able to do that, then we'll come back to the IMCI protocol. So once we understand the common childhood diseases, then we'll go to look at the IMCI protocols, how they apply to those common childhood diseases. Then we look at our health service available for children, and I think that will be all for the semester. But unfortunately, the IMCI component is very big because it entails a lot of sections, so it's very bulky, and that may take us about 2 to 3 weeks to complete. All right, so bear with me. I may be a bit of a marathon here for us to be able to catch up in a way. But as much as I'm be marathon, I also try to slow down so that you can catch up with me too. All right. So when we talk of the lecture for behavioral problems, we're going to be looking at the common ones in children and their common symptoms, how they are manifested, and then we'll look at how we manage them as professionals and then how we support caregivers to overcome those challenges. So we see that parents often wonder what truly constitute problematic behaviors or problem behavior beyond normal childhood growing pain. So beyond raising your child, beyond having to go through the headache of ensuring that the child you are raising meet his nutritional and physical needs, you also have to deal with certain challenges that come with the development of that child. And most of the time, those becomes a challenge for parents, and this become more serious than than we can think. And then, as professionals, it is our duty to help these parents overcome this challenge as much as possible. So, when we talk of behavior problems in children, these things are normal. Okay, there are temporary challenges that occur during development and growth. And once they are normal, that means they are expected to go away at a particular age of this child. So, as the child grows, they disappear. Let me use that word. They are entitled to disappearing and they are not stagnant. So we say that they are often mild and short-term problems, usually improve with guidance, counseling, and then change in the environment. Then we have the other one, which is the disorder. So this one is a problem, and the other one is a disorder. A disorder is more of a persistent one, okay, more severe and outside the norms of the child's age. So when we say a behavior is a disorder, meaning that it has become a persistent and then becoming
Hey, Yomi.
impactful in the life of the child. So under that situation, the child is age is not appropriate for that particular behavior the child is exhibiting. So significantly, it interferes with the social, academic, and then what occupational functionality of the child. And this sometimes require diagnostic what criteria, okay? And then they require professional assessment and intervention. Sometimes it requires some therapy, some counseling, and sometimes medication. For example, a practical example of one is a practical example is the attention deficit hyperactive disorder, which we normally experience in children not being able to pay attention for some time. They easily lose control of their attention. And then we have the hyperactivity in children and then autism spectrum disorders. We know that once a child develops this
Stop it.
at a particular age, if a child is behaving in any of this, then we know that that child definitely has a problem. And with this one, you know definitely you will require what expert input, either counseling, therapy, or what even some extent medication. Now, we also know that these problems, once they progress, they become what heavy burden on parents. They are troublesome. So they begin to threaten the normal relationship between the child and others or interfere with their emotional and social or intellectual development. And as a result of that, most children are tended to be what outside minded in class by virtue of that behavior, which may not be acceptable within them. So, in sociology, psychology has grouped these behaviors into three or four major categories. So, these behavior disorders may be either emotionally, it can be physical, it can be social, and it can be any of other form apart from these three. So when we talk of the emotional disorder, we are saying that it occurs when the child is criticized, neglected, ignored, or abused by a primary caregiver. And then when you do
Oh,
this, the child tend
eh, yo.
the child tend to behave in a manner that you will see and know that what you have done, the child is not in agreement with it. So by virtue of doing that, you may have to deal with certain emotional situations of the child as perfect. For example, temper tantrum is one of the best expression of children towards us when we sit on their rights and privileges and they feel entitled to them. Jealousy, insomnia, nightmare, and terrors are some symptoms of emotional deprivation in children, which as professionals we need to let parents understand. And then even in assessing our children, one other thing is that we need to also look out for physical deprived behaviors. Okay, then they are very profound, just as what we can see as what nail biting, picker, thumb sucking, bed wetting. These are physical deprivation in children as a result of what behavioral problems. So they manifest themselves, and we see them physically, and then the child exhibit them physically, and as a result, some physical deprivation lead to what emotional deprivation. Because once a child is beginning to behave and experience certain behavior, then it will result in the child experiencing an emotional what distance. For example, a child who happens to be experiencing bedwetting may experience emotional torture from his immediate siblings, critics, neglect, ignorance, and that kind of thing. So we are also saying that there's a social dimension of it, and then the social dimension is that the social dimension is that socially the child get deprived, okay, of other factors, other benefits, and then by virtue. Sorry if I see that you have unmuted yourself and you are causing a distraction, I simply put you in the waiting room. So I've already put some people in the waiting room, and if you continue distracted, I'll put you in the waiting room. All right. So it is a reduction of cultural normal interaction between the individual and then the society, and it creates juvenile delinquencies, school phobia, stealing. These are characteristics that within the social environment we do not accept. For example, a child who is aggressive and destructive, most people will not like that child's company. A child who lie a lot, who steal, who has a bit of what jealousy and other misbehavior may experience social deprivation because of those behavior. So the outcomes of this behavior directly put you in a situation that makes you very, very uncomfortable among your peers and among your social environment and even within yourself. That is your emotional stature. Now, let's say that one critical point is that the true behavior problems are more common among preschoolers, but we assume that most of them, by the time the child complete preschool or is getting to the school age, they should disappear. Okay, so common among them is thumb sucking, bedwetting, temper tantrums, nightmares are common among children of late. You find a lot of children experiences, but the recommendations that we do normally expect is that after by the age of preschool, they should disappear. So if it goes beyond those stages or ages, then they become what? A problem, and or what we call a problem at a behavior disorder. Okay. But once within those stages it is occurring, then it becomes a behavior what? A problem which can be resolved. And today we want to look at how we resolve this things. So let's look at thumb sucking as a practical example, and we'll look at each of them, some few of them, about four of them, and see how do they influence our children and how do we, as professionals, help these children come out of it. As midwives, most of the times we experience this thing a lot that even at the time they give birth to a child, after putting the child in a warmer or in a place for drying or something in the absence of the milk, even before you initiate breastfeeding, you will find these children sucking their thumbs or fingers, which is evident from research and from what? Ultrasound that thumb sucking is even in vitro. So in uterus, while the baby is inside the mother's womb, there's strong evidence to show that what? They start what? Their thumbs whilst being in there. And then it is not surprising, therefore, that these children come out and some of them start exhibiting this thumb sucking. So we say that thumb sucking is a behavior that can be grouped under a list of habits known as non-nutritive sucking behavior. So we have two types of sucking behaviors or habits. We have the nutritive and the non-nutritive. So the nutritive ones are what we normally encourage mothers to do, which one of them is what? Exclusive breastfeeding. Once the child suckles the breast milk from the mother breast, then it becomes what? A nutritive what? Sucking habit. Anything the child suckles that at the end of the day add nutrient or help in building his body anatomically or physiologically is what we call a nutritive sucking process. But any of the rivers that does not add value, nutritional value to the child's life or growth and development, it is a non-nutritive one. For example, if a child sucks the thumb, there is no nutrient coming out of it. If the child practice picker is whereby the child eats anything that is non-nutritious. It can be block, it can be a clay, it can be white clay, it can be sand, it can be anything that some have. So we have different type of picker, and then based on the practice of the child, you categorize it. So any of the pickers can be non-nutritive. So thumb sucking is one of the non-nutritive processes that children undergo. But the interesting thing about thumb sucking is that it serves as a what? A comforting behavior for children. Just like we use pacifiers. Okay. So thumb sucking, pacifiers, they are all non-nutritive sucking habits. But for kids, not because of nutrition, not because, but just to keep themselves comforted. Some is a reaction of hunger. And when they suck their thumb, they do not get any nutritional, but they're able to comfort that hunger within them. As they suck the tongue, there is a production of enough what saliva within their system. And this saliva production, Valeria, can you mute yourself or I'll put you in the waiting room? As a result of that, when that happens, they get a bit of fuel from it. Now, what happens to children who do not want to engage in thumb sucking is that they will experience a lot of crying because they do not find other ways of comforting themselves. Now, many infants begin to suck a thumb or finger when they are about 3 months old, and this continues to the first year, about 2 to 4 years old. But it peaks within the age of 18 months and above. So you find that when the child is around 18 months, then around the 6 or 9 months, it peaks, but more peaker at the 18th month and ceases spontaneously by itself between 2 to 4 years of age. So they are saying that the policy is that thumb sucking is normal and does not deform the jaw lines of the child, but as long as it does not go beyond the school age of the child, that's fine. So we know school age is 6 years, and then we are saying that by 4 years the child should have spontaneously ceased thumb sucking by himself or herself without any intervention being put in place. When that does not happen, and by age 4, 4 and a half, 4 up to whatever age, the child is still sucking the thumb, then that is a problem of concern because it's becoming a behavioral disorder. So it doesn't also influence the talking status of the child. Once the child is sucking the tongue doesn't mean that it will delay the speech of the child. Then making an issue of it really causes the child to become more recalcitrant to it. So once you try to stop the child from sucking the tongue, you end up making the child become more recalcitrant. He indulges more in that habit. It becomes more pronounced and then prolonged than you expect it to be. Now, let's see as professionals, how do we assess and classify thumb sucking? Based on clinical observation, thumb sucking is classified into two types. We have the normal and the abnormal thumb sucking. We say the normal thumb sucking is a period whereby it occurs within the recommended age period. So once the child has not crossed the age of 4, it is considered as a normal practice for a child to thumb suck the to do thumb sucking. Okay. But when it goes beyond age 4, then we call it the abnormal thumb sucking. And within the abnormal thumb sucking, some become physiological and some become habitual. And the difference between the physiological and the habitual happens to do with the duration of the sucking, the frequency rather. So we say that the normal thumb sucking include the period of the preschool infant, what lasts from the time a child is born until around the age of 4, depending on the child's social development. So during this stage, most infants, especially around the time of weaning, and it's considered normal. So you wean when you are weaning the child, you are reducing the breast sucking rate of the child. And but the child has already developed sucking reflexes, and there is always an urge to suck. So once you are not providing breast at frequency at that time, the child is tempted to comfort himself with the thumb to reduce, to kind of satisfy the sucking reflexes that she or he has developed in that process. So that's why during the weaning stage of a child, you find most of them are doing thumb sucking. Now, with the abnormal one, the physiological thumb sucking is a process whereby it continues from 4 to 6 years of age. So there's a range for the 4 to 6 years. Once it crosses 6 years and going, then it becomes a habitual process. This persists and forceful suckling becomes obvious. During this period, it merits more serious consideration because the likelihood signals clinically substantiate anxiety. So a child within that age who does a lot of stomach sucking is either anxious or something, is either frightened by something, or is now at the time to address dental issues. So maybe the child has a dental problem that he always tries to satisfy that dental sensation by sucking the thumb, or some even go to the extent by biting the fingers. So we find them chewing their fingers. And these are some of the things that give us the negative outcome of thumb sucking. Now, habitually, thumb sucking that continue after a child 4 years is an issue of dentists. Now, during this phase, a thumb sucking habit may require physiological therapy as well as the integrated approach from the dentist. This stage continue to teenage child. So I'm saying that once the child crosses 6 years and still continue to do a lot of thumb sucking, that the frequency increases, then it's no more a physiological problem, but now a habitual problem. But you cannot solve that habitual problem by just looking at the habit, but you must also solve the physiological aspect of it, which involve a therapy services. whilst including a dental aspect to also assess the dental orientation of the child in order to prevent what? Other dental problems. Okay. Now, if you are able to identify and classify the suite where the child is found, it is very important for you to also let the parents what? Understand. Ernestina, Kuridon, can you mute yourself? Mariam. Okay. Conde, Mariam. All right. I mean, this is the last time I mentioned somebody's name. So once you understand that there is an effect of once you understand that there is an effect, you understand the kind of situation the child finds himself, either it's habitual, physiological, or what, a normal process. But some comes with what? Side effects and complications. And one of them is what we want to look at this blessed morning. We want to look at what are some of the effects of what? Thumb sucking. So if thumb sucking continues, negative consequences can occur. Remember, I said that what? Once thumb sucking does not exceed 4 years, it is not considered to be what? Detrimental. But even within the 0 to 2 years or 4 years, certain habitual way of sucking the thumb can become what? Detrimental, which we call the trident of factors of thumb sucking. So the trident of factors of thumb sucking are three factors that determine whether there will be an effect or there will be a complication as a result of that thumb sucking. And these trident are what we call the frequency, the intensity, and then the duration of the thumb sucking. So once the frequency is becoming more rampant, if the child is sucking the thumb more rampant every now and then, the slightest opportunity, the thumb is in the mouth, then he is sucking with a rigor of force. Some include biting, chewing the finger or the thumb while sucking with very intense pressure that you can even hear the strength of the muscles contracting each other. And if it is being sucked for a very longer time, so the longer the duration of the suckle of the thumb, the more negative effect you will have occurring in the one in the thumb, okay. And so when these three factors come into play to their highest extreme, to their maximum capacity, then you can have a deformity of the nail, okay, which is characterized by pain, redness, and what I can think of. Some even swelling and then form in the finger. Now, there can also be dental malocclusion, which can result into the unalignment of the teeth. So what that means is that you find the teeth of the child inappropriately aligned. So if the teeth of the child is inappropriately aligned, then we find ourselves in that situation, what we call dental what? Mal what? Occlusion. So dental malocclusion simple means that what? The teeth of the child is not properly aligned. So the upper jaws and the lower jaws are what? Not adequately aligned. So one is overshadowing the other. Okay. Now we have blisters located in the affected thumb due to the intensity of the sucking. So due to the intensity, you are the child suckle and is pulling the tendons and the muscles on the thumb. Definitely, they will give us some form of blisters, and then these blisters can become infectious. And once they become infectious, then you have the child having other problems of both oral cavity infection and then the thumb infection. Then there's a delayed developmental achievement of the oral functionality. Once there is an infection on the oral cavity, the dental cavity become infected, then there's going to be a delay in certain functionality because certain teeth may never come out because the space may get occupied by the thumb during sucking or may get infected, and as a result, the child may not achieve full oral, dental maturation. And therefore, once the child does not achieve full dental maturation, then definitely he will not have the full of what oral functionality. So how do we handle these situations when we come across them? So when we come across them, what do we do with them? Okay, it's what we want to look at this morning and see again. Under this session, let's look. If you find a child that has a thumb sucking, and as a professional, the parent of that child has come to you, what will you do to help that child and the parent to have comfort? So the first principle is that We believe that in medical practice, EE is everything: early detection, early investigation, early diagnosis, early treatment, and we get a positive outcome. Once we do not achieve these three, then we can be rest assured that we will not have a positive outcome. So we see that early elimination of digit sacking habit is the best and one of the most important factors in achieving favorable treatment option. So once you do not achieve the early detection. So one thing as professionals should know is the age recommendation. At what age is this going to be a problem for the child I'm having? Okay. Is it a problem that this child at age 3 is sucking the thumb? Yes, it is a problem, but it is also not a problem because the policy has made us to understand that the principles are that after 4 years is a problem. But it becomes a problem when it starts developing some complications and having an effect on the child's life cycle or the nutrition or the growth and development of the child. So we said this is done naturally, okay? This is done by naturally feeding the child through breastfeeding. So we also remember when I started the lecture, I made mention of one critical component that as a result of our feeding practices, sometimes these children use these behaviors to comfort themselves and find alliance or self-identity or self-composure. So if your child is adequately breastfed and to the field, then there is no cause for thumb sucking. Now, someone will argue that children right after breastfeeding put the thumb in their mouth and there's yes, so that is not a response to hunger, but that is a response to comfort. And remember I said that one thing about non-nutritive habits are not for satisfaction of nutritional needs, but rather for a comfort of behavior. So once the child does that, he's only looking for comfort. But evidence also shows that when a child is adequately breastfed and then or it adequately fed well to full, then it has a tendency of reducing thumb sucking. Well, one other sign that lead to thumb sucking is hunger. Very fundamental, can be ruled out. All right. So let's see. So several treatment options have been proposed for thumb sucking. One of them is you have to educate the parents or the guidance or the caregivers of this child to understand that these are behavioral problems in children. But until the child crosses some age, they do not become a behavioral disorder. And once it's not a behavioral disorder, we expect that as the child grows, he should drop it simultaneously. He should do it by him or herself because as the child began to recognize and identify himself. Remember when we're looking at growth and development, we said that at some particular age, the child begins to do self identification. So once the child begins to do self-identification, the child is expected to drop certain behaviors she or he may find as not identifiable traits of him or herself. So a child that is beginning to feel shy may begin to drop some of these behaviors in order not to embarrass himself or herself. Okay, so we need to let parents and guardians and caregivers understand this principle. Then, in the advanced stage whereby a child goes beyond the recommended age and still practice this thing, then one other principle are what we call the mouth and the hand appliances. So we have certain appliances and devices that we can use to make thumb sucking uncomfortable for this, and one of them is the palatal grips. Palatal grips or palatal lockers or cages, with some people call them, can be devices that are shoved into the mouth of the child. So when they are shoved into the mouth, the device has a rubber-like lining, would prevent the palate of the child mouth from directly coming into contact with with the tongue. So when you put that device in the mouth of the child, and the child put the hand inside the mouth, the rubber-like lining prevents the child from enjoying that sucking process. So there's no contact. There's no second contact or reflexes between the palate, the tongue, and then the tongue of the child. And once the child does that one too and doesn't enjoy that habit, definitely it will lead to the child withdrawing that habit. Then we also have the handshakes. So this is a picture of how the hand racks look like, or the cage type appliance for hand look like. You see that on the thumb of the child is a plastic like device being worn. And that plastic-like device, when the child wears that one and tries sucking the thumb, then he doesn't get a direct contact with the thumb by itself, but the plastic serves as a barrier. And that barrier becomes unpleasant for the child to suckle. And by virtue of that, will definitely lead that child to stopping the behavior at the appropriate time. Now, we also say that implementing behavior modification techniques such as advice and incentives for changing behavior. This is targeted at those who are matured and understand. Example, if you have an 8-year-old daughter in your house or son in your house who is engaging in thumb sucking, by engaging the person in better understanding in advices and incentives, will let this person drop the habit. For example, you tell your child that, oh, if the whole of today I don't see you sucking your thumb, then you have a reward for the person. Once that habit continues, today he doesn't do it, tomorrow he doesn't do it, 3 or 4 days he doesn't do it, then definitely you can be rest assured that the child is going to eventually drop that habit. So you start for a day, okay, a day you pass, okay, 3 days. If I don't see you suck your thumb for 3 days, I'm going to give you a reward. He passes that 1 week, 1 month, and before you realize the child has dropped the whole behavior in totality and is back to the normal status quo. We are also saying that in the event of some situations, which most of us know and most of us do, is the application of nasty tasting substances to the thumbs of these children. And a clear example is some of us use kuni, some of us use what we call swaka in my language, but bitter leaves, if you that's the English version of it. Some people use pea more. So a lot of people have funny things, but the most important thing I want to stress under this particular topic is that if you are coming to use a nasty tasty substance, make sure that that nasty tasty substance does not end up being harmful to the child. Because if you go and use a nasty tasty substance, that when this child ingests and it will end up giving the child another problem, then you are doing more harm than good to the child. So let's be cautious of what we use as a nasty tasty substance for these children, because at the end of the day, you are trying to promote health among them and not to give them a disease or an outcome of negative effect. Then we also call it the myofunctional therapy, which is the combination of all these things I've mentioned. So you can either use a nasty substance and still apply the cleft palate, palatal grips, and you can still apply the thumb. Now there's even a third one which we call the elbow shrink. So it's a device you wear on the elbow of the child, and that device or that material or appliance prevent the child from being able to fold the arm to the mouth. So when the child is having the habit or the desire to thumb suck, and he try bringing the hand to the mouth, once he reaches some level, the device will block the continuity of the thumb to the mouth. So it serves as a blockage. So when you do that, you see that the child will try one, two, and there will be a resistance by the device. And by virtue of that, the child will eventually have to drop the sucking behavior. Then we say that what you can also refer to a pediatric dentist to evaluate the dental complication of tongue sucking. And then by also considering the habit, the persistent age of 4, as I mentioned. So despite appropriate behavioral intervention, you also need to let the dental people assess the dental orientation of the child to see whether this child is having everything in shape or not. Now, what happens is that if the child have a dental issue and you do this, at the end of the day, you can correct the child dental issue and make sure that that child has no problem with dental orientation, dental malocclusion, or whatever. But if you allow this child to continue with this behavior without you checking the dental occlusion issues, the child will stop the thumb sucking at some point in time, but will have other oral dysfunctionality. Now, also, as I earlier mentioned, it's a professional jam together. So it consists of a team of experts. So never try to tackle Tom Sacking as a single personality of a profession. But you need a dental person, you need a pediatrician to look at the psychological and the medical aspect. And we need a psychologist to also counsel the patient on integration into possible society. All right. So that is that for thumb sucking, and then how we can help a child to overcome thumb sucking practices. So the principles of that thumb sucking is that first of all, you need to let the people understand that these processes are age specific, and then they will go as time goes on. Please, Lydia, kindly note your question down. I'll get to a place for questions, and then you can ask your question. Okay. Yes. So bedwetting in children. We say bedwetting, or what we call neuresis, is the involuntary passage of urine past the age when a child should be expected to have attained bladder control. So a child that is about 2 to 3 years is expected to achieve bladder control during the daytime, and a child that is 4 years old and above is expected to achieve bladder control for both day and night. So if this does not happen, then a child is having what we call bedwetting behaviors. Now, we are quick to classify children under bedwetting because once the child just sleep, for example, if you put a 2 years old baby child on the bed to sleep overnight without wearing him diapers or controlling the child, then the child sleeps in bed wet. You can't conclude that that child have what we call what inerrances. No, you can't conclude because what happens is that the child, per the policy or the guideline or the recommendation, has not yet attained the age whereby he should be able to control what his bladder. Okay, so we say that what bedwetting or neurosis normally occur between the ages of what 5 and 7. So after 5 years, if your child continues to sleep and wet his bed, then you can confidently diagnose this child of what of bedwetting. But lesser than that, then you may be doing a harm to the child. In other sense, we also have what we call the primary and then the secondary. So the primary type of bedwetting is when the child is what has not been trained to control his bladder. But the secondary is when the child has been trained and he loses that training, like in our old aged parents. In our aged parents, as they grew up, they could control their bladder, not peeing on themselves, whether day or night. But as they grow older, they get to the stage that if care is not taken, when they sleep, they pee on themselves. Okay. I quite remember someone told me that the only dream that comes true is bedwetting. Okay, you dream that you are in the urinary urinating and you wake up and you find the bed wet, you see, and that is very true. So if the child does not attain bladder control, then you will always be experiencing the only dream that comes true in your life, which is what bedwetting. So we have either nocturnal, which is very often daytime, nighttime bedwetting, even though we can have the daytime one or both of them. But the most important thing is that the child has to be what trained to control the bladder. Okay. So functional nocturnal neurosis, that which is no case occur in, so the presume the rate is high. So out of every 10 children, you can find eight of them being what experiencing bedwetting even at the age of 8 and younger, which is a problem because bedwetting ideally is supposed to stop at 4 years. So beyond extra 4 years, more than 8% to 12% of children are still bedwetting, and that is a problem initial, but now is when it crosses that age, then it becomes a disorder. So there's a profound evidence that it is more frequent in boys than in girls. So because of their structural differences of what their urinary system. So more boys have more free flow of bladder flow than younger ladies because of the location of the two bladders in each of them. Now it's also genetic. So they say that if your child is bedwetting, the two of you have to ask yourself which of you was bedwetting when you were younger. So it is family. So it is present in a child, meaning one of the parents probably experienced it when the parent was young. So if you have a sibling, if you have a child and your child is bedwetting, you need to ask your spouse or ask yourself or ask your parent whether when you were younger, were you bedwetting? Or ask your spouse parents whether when your spouse was younger, was he or she what bedwetting? Is very important for us to know. Now, there is also a measure or assessment of bedwetting. Remember, I said that in healthcare, the principles are that the ages are very important. That's why we started with growth and development. And then we look at the age specifics of growth and development. We look at every child and his age and his growth and his development attached to them. So in assessing every condition in a child, the assessment is done in respective to that particular age. So for example, we talked about thumb sucking and we said preschool, school age 4 years. 2 years to 4 years. Bedwetting, we are talking about 5 years and about 5 to 7 years. So understanding these age categories are very important. But in the first place, it helps you whether you should be worried or not as a professional. And if as a professional, if you are worried, you'll be in a better capacity to advise the parent to also be worried or not. Okay. All right. So let's see, how do we assess it? So children with bedwetting who are older than 5 years of age need an evaluation to determine whether there is what an organic cause for the disorder. Okay, so if the child is more than 5 years, older than 5 years, and is still doing bedwetting, you need to let them do an assessment of the child to see whether everything is all right with the organic structure of the child, the urinary tract system of the child. So you have to let them assess. Maybe the child has maybe prostate issues, bladder issue, or maybe the child have some anatomical deformities around the UT system that is making inability to have what we call the bladder control system. Now, you also thought through the history taking that you have to assess to see whether there's a history of bedwetting. Find out from the mother or the father whether they had been bedwetting when they were at the age of the mother, at the age of that their child. It's part of the history taking. Once we know that it is family. And then as parents, we should also find out to know whether we were bedwetting so that we can condition our mind to help our children not to bedwet so that the chains can be broken at any point in our generational line. Now, professionals must also pay key attention to the medical history of the child, whether the child ever had any UTI, any other form of conditions. Then you also pay attention to family history. I've talked about it. How psychologically stable that child is, the sleeping pattern of the child, physical examination, bladder functionality, and among others. We talk about fluid intake, how the child prepares himself before bed, quantity of water intake, and that kind of stuff. So you ask how parents have tried to correct the problem. So first of all, you have to encourage parents and guide them to also acknowledge their effort being put in place by congratulating them whilst you try to find out their measures they have taken so far. Some of their measures may have the psychosocial impact on the child. Some of them may be traumatizing for the child and might end up putting the child in such a situation. So you identify whether it is a primary problem of a child or it is the parents who want it. So assessing who is actually ready to stop bedwetting is very important. Is it the child who wants to stop the act or the parents are forcing the child to stop the act? Until the child realizes that the bedwetting is a problem, you will not see the reason why he should stop. So first of all, the child comes to a self-actualization that what I am experiencing is no good for my health and I need to stop is very important. As professionals, we need to let the line be clear. It's not shouldn't be a problem only for the parent, but the child should also realize that what, it is a problem. They assess whether there are stresses in the family. So sometimes we stress these children with high expectations that, oh, you once we have given birth to another child, you there you are an old man, even though you are 3 years and your younger one is 1 year. Our focus is on the younger one. No, the focus should not be like that. When you do that, you are stressing the child to maturity, and by so doing, the child cannot handle that kind of stress and may find him or herself. For example, you are supposed to wake that child up at midnight to possibly go and urinate or put that child on pampers. But if because you have a much younger one, you expect him to behave and even possibly even wake up his sibling one to go and urinate, and this become uncomfortable for the child. Sometimes the environment they also find themselves urinary location, maybe where the child will go and pee and come back and sleep, is so distant and so fearful for the child to go. In that case, the child will just choose to pee and free himself on the bed instead of having to engage the anxiety or fear of going to the urinary to go and free him or herself. We are also told that marital situations can distort the children by giving them an abusive mind and an unstable mind to have the freedom to develop those habits. So what do? We assess for other possible UTIs as abdominal pain, burning sensation, which are these are common symptoms of what specific UTIs you can think about. Then I spoke about hereditary as a form of assessment. You have to find out whether there was a possible behavior among either each of the parents. And then we also spoke about what you assess the environment, as I've spoken about, where the child sleep, how where he goes to pee, how close are they, what is the comfort of the sleeping position place of the child and the where the urinary, do they make available devices or instruments for the child to easily free or pee. All these are things you have to access as professionals to ensure that what there is a conducive environment. And now children who find themselves in new environment, evidence prove that they easily what pee on themselves at night. And that is because of what uncomfortability within the environment. Now let's look at how to manage children who had bedwetting. The treatment of bedwetting may be complex because it causes is generally unknown. Remember, I said that it's a multifunction activity. It doesn't have a specific cause. A lot of factors can come into play depending on where the child is, the psychological status of the child, family history, and others that I've mentioned. So first of all, we say that you have to address each of them systematically based on your assessment. Remember, you took a history. So based on the history, you look for the causal factors. So we have what we call the 3A. You assess, you analyze, then you take an action. So once you do the assessment, based on your assessment of the indicators that shows that what these are the pinpointing factors, these are the predictors of what of the child bedwetting behavior. You now analyze to come up with those predictors, and based on that analysis, you take an action. And that action does not just mean you alone, it's an action between you and the parent. So we say what suggest instead of what advising them. So you suggest to the parents that these are the situation. Your analysis shows A, B, C, D, and these are the recommendations. But the simplest of what is what we're going to look at. So the first of all, we say that resolve stress factors within the child and the family. So if there are stress factors, if there are abusive factors, if there are factors that you have identified, such as violence in their family that make the child uncomfortable, such as expected adulthood of the childhood. The child has not yet reached that stage. High expectation, you have to address them so that the child can be as much as comfortable as possible in order not to find himself being stressed out. Sometimes when you're under a stiff pressure, you can pee without knowing. For example, let's use a simple pressure like they put a gun in your mouth. But at that moment, two things, three things may happen. Both openings in your human system will start bringing out whatever they can bring out. You know what I'm talking about. The top and the down all will bring what they are supposed to bring out. So depending on the pressure and the stress the child is going through can lead to certain behavior. Some even beside bedwetting, if they're so stressed, they can even shit on the bed without even knowing that they have done it, only to wake up to find that kind of embarrassing behavior they have found themselves. So we also say provide education and motivational intervention for parents and children. So if the child is understandable, has reached a stage where he understands, you have to let the child be guided that these behaviors are not healthy, and you find them, and you also let them find reasons why they should stop. Because when you give them motivations, definitely they will stop the act. Now we also say that what provide so in providing the education, you are not limited, sorry. You are not limited to what I'm talking about, but you have to talk about what the fluid intake after dinner. But when it comes to children who have sickle cell anemia, we do not put them on fluid constraint or restriction. Anemia, children with sickle cell coupled anemia, they demand a lot of hydration levels. So if we limit their fluid intake because we want to control bedwetting, we end up putting that child in distress, and we may end up losing that child entirely. But in a normal child who you want to control bedwetting, limit the fluid after dinner or fluid intake at night. Sometimes just a sip to cool the throat and not to satisfy the tummy is very important. There's also an alarm system that has come into play. Parents install it in the panties of the children as they sleep. So the least pee that comes out of them UTI system into the pant and touch. Any little bit of wetness, the alarm will blow on the child, and the child will be compelled to wake up and go and pee. But the problem with the alarm system is that once you withdraw the alarm system, the child becomes what? Can return back, relapse. But if it is done for a while, then the child develops the habit of waking up at that particular time, a habitual resurrection at that time to go and pee, then the alarm system will work perfectly. Then caffeine and high sugar drinks easily give us dehydration. And once you become dehydrated, you end up what taking more water. And caffeine and high sugar also is an intrinsic factor in terms of high urine production. So what happens is that if you give your children, I know most of us don't give them cafe, but we give them sugar drink, carbonated drink. So we encourage that children should not be given carbonated drink at night to drink. Be it Fanta, Coke, you know the carbonated and the sugar drinks I'm talking about. Fruit juice is different. Natural fruit juice is different. But even with the natural fruit juice, we do recommend limitations to it, especially at night, because you do not want to put in high sugar in that child. And we even know that at night there is little energy expenditure. So more sugar in the system of the child will definitely lead the child to one of the non-communicable diseases in his life cycle as he grow older. So we avoid caffeine and high sugar in children so that they do not get dehydrated. And when they do not get dehydrated, they do not get themselves hydrated with excess water, which will result in them bedwetting. Then we say help the child train their body. So we have what called the bladder stretching exercise. So you can start with your child by doing the bladder. So when the child wants to pee, you ask the child to hold the urine for some few minutes. So my child comes to tell me that, Mama, I want to pee, I want to urinate. So you say, oh no, hold it. Stay for 5 minutes. So today he holds it for 5 minutes. Another day he holds it for 10 minutes, then 15 minutes. So you are stretching the bladder and the child is at quitting to holding them. This helps better when you are even traveling with the child. So if your child is able to do a good bladder control mechanism in place, when you are traveling, sometimes the child want to pee, you can say, oh, hold on, let's get to the nearest place. The child can be able to hold onto it. But when the child cannot control the bladder, does not have a good bladder control mechanism due to the bladder stretching in exercises, then the child will definitely have those issues or what urine outlet at any time. Then in the advanced stage whereby you cannot do any of this or you have done any of this and it's not working, then you may have to add some form of medication. Antidiuretics help better. And we all know what antidiuretics does to these children. Now, you also have to provide some education and set resources for parents. And one of them is that you must encourage the parents to understand that these are processes and not a time event. It's a process and not an event. A process means that it takes gradual time to get resolved. An event means it happened at a go. This bedwetting resolution or terms or these behavioral problems are processes that take place, and therefore they require processes in resolving. They are not event resolutions. So you have to encourage them to be more patient and keep trying their skills. You can't do an intervention today and it will work today. It takes time to resolve. For example, if you are doing bladder stretching exercise, if you do today, the child may fail. You say, oh, hold it for 5 minutes, and 3 minutes the child want to pee. It's an achievement. You have to encourage the child to continue before the child finally achieves this 5 minutes and to move forward. Then remind parents that the child is not at fault because it is a growing developmental activity. Every child that is going past through that stage, and once he passed through that stage, it is not his or her fault. It is rather the efforts of the parents in helping the child to control and develop that expertise or skill to control it that will rather help. But when you punish the child and make the child feel worse than before, you are doing more damage to this child and you are harming the child more than you are doing in terms of solving the problem. Then provide referrals wherever you think that is a disorder that need other specialist care like urological surgery or urological assessment. If you see that there's a UTI problem or there's a urinary infection somewhere. All right. Is there any question? Any question? We'll spend the next 2 minutes taking question, and then after that we'll continue. We have a lot to cover. So someone hand was up, and then I said to hold your breath. Please. So okay, Infinix Hot 10. Who is that? Before you talk, rename your this thing before you talk. All right. Please, those of us who join with our phones and without even adding our IDs and stuff, at the end of the day, when I go for the attendance list, it will go against you because after every lecture, the attendance is produced by the IT and it's your ID numbers we are working with. So if you join with your name and your ID number is not there, that one there will be your problem. But on your scannable or on your screen, you write your ID, you don't write your name there. So you don't expect me to now go and pick your details and be tracing for who's this name, what ID corresponds with. No, I won't do it. So please, we all know what to do. Let's do the needful and then we'll all be in good business. I don't want anybody chasing me because of marks. No. I don't want that headache. So please, let's not put ourselves in that situation. Auntie Lydia, please, you can speak. Lydia, please ask your
Hello,
question.
hello, sir. Sir,
Yes.
please, about the term suckling. Is it hereditary? Because one of my aunts, all her sons, four, when during the process, all of them they suckle their term. So even the second son was in GSS still suckling. So I wanted to know whether it's also heredity. And the second question is, the management. Can you say exclusive breastfeeding should be frequently, because some of the children immediately you deliver them, they are putting their hands in their thumb. So I think when you breastfeed frequently, then you position yourself for I think the child will not do the thumb suckling. Then you have socks, baby thumb socks. When you deliver,
Okay.
you put them on their hands. Some
Yeah.
of my second child, wanted to do the thumb suckling. So every day you will see me putting socks on the on their hands. So I think it helps. So
Yes, yes,
it's
yes.
a good. You can also practice that one. Thank you.
Thank you, thank you, thank you. I think the
And the
socks.
bedwetting too.
Yes. So the other thing I forgot to
Sir,
add
please, I
is
haven't finished.
okay. Go
Say
ahead.
about the bedwetting. When you went to nursing, midwifery nursing, there is this lady who usually bedwet. I don't know. He said she have been in hospital, specialists everywhere, but still she bedwet. And I don't know. So what can be the cause?
Okay. Okay. Are you done with your questions?
Sir, thank you.
Thank you. All right. So let me respond to her question and then I'll pick another set. So yes, thumb sucking is a normal thing for every child to do. So because it's normal, it's difficult to say it is hereditary. Ideally, the evidence point that every child at every stage will definitely do thumb sucking as a way of just comforting himself or not necessarily because the child might be hungry or something, but just to look for comfort or for example, if a child persistently cries for a long time without any response, the easiest for the child to do is to do thumb sucking. So yes, some school of thought are associating into hereditary, but there is no research that specifically has concluded that thumb sucking is hereditary. Unlike bedwetting, that there are some evidence to associate that bedwetting is hereditary. Thumb sucking has not been associated to be hereditary. Now, the key line is that, or the thin line is because thumb sucking happens to be a bit of a normality in child growth. And so it is difficult for you to just conclude that it is hereditary. You get me? And then for the socks, wearing of the socks, that is if the child is still not so hyperactive. When the child gets to some stage and is becoming very active, when you wear the socks, the child can easily remove the hand socks by himself. Okay, and that state it becomes difficult to wear them. But it's a good recommendation, and I've seen it being tried on some children at the early stages, and it has worked perfectly, especially between 3 and 6 months. If you're able to train the child from not sucking the thumb, then you can have a good chance of not having one sucking it at the latter stages. Then the bedwetting in the seniors, our senior college, it is that one will be more of for me. I think it will be more of a urological issue because at that age the person have cognitive recognition, except the person is a deep sleeper, which is now a psychological problem. If the person is a deep sleeper, that in the sense that in his sleep, that is the dream that comes true for her, then it is different. Now, remember that there can also be stress factors. Even as adults, as we are under so much of a stress, you can bedwet. Occasional people do it in adult age. For example, if you go out and that night you had a lot of food and a lot of water, coupled with so much stress, like you're taking a lot of alcohol, and you fall into deep sleep. That deep sleep can lead to bedwet. Okay, because you have depression from the alcohol. Now, frustration and depression are factors that can also let adults. So that's why we say that when there is adult bedwetting in adulthood, then the thematic analysis, you need a psychologist, you need a pediatrician or a urologist. The spirit is with us, we know. Amen. So the for the bedwetting in the adult, there are a lot of factors that can happen, and so if she has been to a lot of hospital for assessment, then I don't know what assessment they did, but for policy and for practical purposes, you need not to just be looking at the fact that the person has crossed the age, but you need to look at the other stresses, the level of psychological stability, dietary practices, okay, sleeping practices, and even lifestyle practices. There are some lifestyle habits when you examine, like if alcoholic intake, high alcoholic, intense alcohol intake, you have about 70% chances of having bedwetting, because if every time you are intoxicated with alcohol, then you cannot have the proper coordination of your system in a way that you know that at this time let me go and pee. So you always be having urinary dreams in your bed, and you'll be bedwetting. So for her, she may need an extensive analysis of her whole system, including social, behavioral, and then what? Anatomical structure of the UTI system. All right. Barakisu. I can't remember who raised their hand before, but Barakisu, please, you can ask your question.
Thank you, sir. Yeah, some children about 10 years, when they are bedwetting, especially in the evening, some parents give them dry gari to take without water, and they relate it to the fact that it will like reduce the rate at which the child bedwets. I don't know how true it is. And then secondly, the thumb suckling. I knew of a child who always reported to the facility, and the diagnosis was pneumonia. Always the child is sick. So later the mother weaned the child to the grandmother, and the child went through some training from the grandmother and he stopped the suckling. So later the sickness was not that rampant. The child was okay and was attending school. So during delivery too, related to the umbilical veins and the arteries, I learned that when one of the blood vessels is absent, it is linked to any kidney issue. So if the midwives, we are able to rectify that at the early stage, the child might go through some processes to rectify those issues if and only if it's related to such issues. They will correct it and the child will be okay. Thank you.
Thank you. So that's your last point is a very valid contribution, and I appreciate that. I came across it when I was reading about other measures or risk factors of thumb sucking and then bedwetting in children, especially bedwetting. Sometimes pregnancy stages, unfavorable or defect in pregnancy, sometimes as a factor of that. And then with your first question about then you spoke about the woman winning off the child
Gary,
to the grandmother. Yes, it's also another process you can use to but I was thinking that you would have elaborated what happened with the grandmother that prevented the child from thumb sucking. Uh-huh. Hey, come
initially
back with your first question.
the first one was about Gary, like
So
when
let me quickly answer that. So yesterday, when I was having the other class, when I was talking about how to control bedwetting, someone said Gary, and the person gave me evidence that she used Gary for his Form 1 girl at senior high, and the person stopped bedwetting. Now, what happens to Gary? Gary is how do I call it? Dry Gary is a sucker of water. If I may use that word in quotes, okay. It's just like when you put Gary down and you soak it. Within some few minutes, you see that it sucks, it absorbs all the water. Then you add again, then within some few minutes, it absorbs again. There is no scientific evidence, but logically, I want to believe that that's what is happening. Because if the person take the Gary, high starch attracts water. So when the child takes that dry Gary with sugar, and remember I said sugar lead to dehydration because it absorbs water. Now, if the child take the Gary, then definitely the system will absorb whatever fluid that is available to make that Gary wet for what digestion. And so there will not be excess water to be passed out as urine. But remember that you can also cause dehydration in this child and can lead to what? Dehydration complications. Okay. So for the Gary, scientifically, there's no evidence. I've not come across a scientific evidence on it. But logically, this is the basis for understanding the philosophy behind absorption of carbohydrate. like dry carbohydrate, you can agree that what you need absorption and digestion rather. Digestion take place in the presence of what? A liquid or solid media. Okay, so once you take ingest dry gari will need a liquid media for digestion to take place, and as a result, that will be the outcome of it. So it was a bit cheap in soon from the system of the child to aid in digestion. Is that understood?
Yes, sir.
Okay.
So okay, so that's fine. Thank you, Barkisu. I'm grateful. Yes, Evelyn. So I still have two hands, three hands. So after these three hands, I see a lot of comments in the comment section. I'll try to respond to some of them. Evelyn, please speak. If not, Benedicta, if you are ready, you can
Okay,
speak.
sir, please. Good morning, sir.
Good morning, my dear.
Sir, please, bedwetting. Some people relate it to a spiritual attack. Please, I want to know how truth it is.
Hey, Evelyn, this one
Secondly,
you said
when can you diagnose?
spiritual attack.
Yeah.
What is the
And
evidence the
secondly,
person have to show that is spiritual attack? Look, at our age or at where we have reached, we are speaking scientific, and then the scientific basis are clear. At this moment, I don't expect you to ask me about spirituality issue in relation to that is a belief system. Okay, it's a subjective area. And once it's subjective, I can't delve into it because I don't have evidence to it. If I tell you that yes, it can be spiritual, what is my evidence to it? I do not have the evidence. But it's subjective, it's a belief system. And we know that spirituality is what you believe is what works. So what I have evidence to is what I have shared with you, and which we can all, as professionals, we can all agree that yes, we also, as human as we are born in a spiritual enclave, surrounded by spiritual, of which we ourselves are spiritual beings in our second selves, we can attest that what there can be some form of spirituality to it. But I cannot sit here and tell you that what the person said is true or not, because for spirituality, it's individually beliefs. That's why I've not even added it to the cause or the risk factors, but I've stressed on what scientifically has been proven for the benefit of the doubt, in order not to enslave yourself in any entanglement. Okay, so I think that for that one, Manenda Hawaii.
okay, okay, sir.
Yes,
But
sir.
sir, secondly, when can you diagnose that somebody is like bedwet? Like, is it infancy or like I don't know whether you understand my
I
question.
said in the slides, I said that bedwetting for daytime is expected to be controlled by age 3 years. So after 3 years, if your child is still wetting himself during the daytime, it's a problem. But for night is after 4 years. So 5 to 7 years is the age range for diagnosing of bedwetting. So from 5 years going, if the child is still bedwetting, you can now diagnose the child as a behavioral disorder of what? Bedwetting. Okay, so that is the cutoff from 4 going. A child is not expected to bedwet anymore.
Mm,
Yes. All right. So if you are okay, then
okay.
all
Thank
right.
you, sir.
Benedicta, your hand was up and it's still up.
I want to ask, I have a daughter, she's 7 years. She doesn't start her tango, she starts her
Benedicta,
dance.
I can't hear you. I can't hear you. You are far away. Your voice is far away.
I'm saying that,
Yes.
Please, can you hear me now?
Yes.
I have a daughter, she's 7 years now. Then she starts the tank. She will be holding you or pinching you and be starting the tank. I did
7 years.
everything for her.
So it's
7 years.
so he's expressed something is that one is something is triggering it. It's a behavioral problem.
Eh,
Something is triggering it. So it's he's responding.
when I have to leave her, I've not weaned from the breast, but I left her and went to school. So I think she has developed a comforting distance from there, and I tried stopping the action of 7 years. She's still doing it.
Yeah, so it's a comforting behavior she has found. So at that age, you need a lot of factors to control. Remember, I spoke about you need a psychological stability. So something triggers it. So find out what happens before she starts. It's a response she's demonstrating to something. Maybe agitation, suppression, unmet need, a reaction to unmet need, or is a response to hunger or something. But at that stage, it's no more, it's habitual. So habitual, something is triggering it. And until you find out what is triggering it, you cannot solve that problem. Okay. Now the other thing, you have to use motivation. In his case, you have to use advice and motivation. You have to find a way of you and here talking and coming to an agreement of some terminologies for rewarding purposes. And when you do that, I think it will also help based on what we have experienced on the field. Okay.
Okay, thank you, sir.
All right. So please, the hands are too much. I still have a lot of to cover. Let me leave them. Note them down. We'll respond to the rest at the end of the lecture when I get to where I want to. Okay, please. Let me respond to some few comments. Drooling in children. Drooling in children is also one of the issues that is coming up. But you see, until a child has a brain issue, drooling is not supposed to go beyond 6 months. It's not supposed to go beyond 1 year. Okay, the ability to control the saliva dripping from the mouth. Even in some places, they are saying that by 8 months it should stop. But for our setting, because children develop at different pacement and different rate, we are saying 1 year. But it should stop, except the child have a brain problem and a nerve coordination issue, okay, a neuro problem, then that will become a problem. So when drawing goes beyond that age, you need to seek expert advice for that. And most of the time, we find them with children who has CPS, cerebral palsy, and then seizures, a lot of epileptic and seizure cases whereby they have those issues. So for that reason, you just have to uh, seek expert advice for children who have drawing beyond that age. All right. So I think most of your comments I have addressed them, and then I will continue with. Let's look at aggressiveness in children. Okay. Mubarika, I'll get back to you. Just note your question down, or you can leave it in the comment section so that I will wrap up my lecture and we can have amplified. If you want to discuss all the comment, we'll never finish the lecture. Aggression in children, it's a big problem. They are very aggressive at some particular age as a result of what development in them. So, say aggression in pediatric clients is a complex and growing concern in healthcare because the negative effect is much. It affects both we, the adult, and then you, the health professional who is taking care of the child, suffer aggressive behaviors, and then the parents. So children may lack the developmental skill to regulate their emotions and communicate effectively. So that's why when you do something and your child is not happy, he expresses it by either being aggressive, being crying, or being what. So they are a response to what either frustration, fear, or when their needs are not met. Okay, so we say that what pediatric aggression is a verbal outburst such as yelling, physical incident like hitting, kicking, and self-injury, and proper distraction. So when a child does this, it's a response to either his or her frustration level, his or her fear, or his or her unmet need. So this aggressive behavior poses significant safety risk for both the professional and the family. And so if these are not resolved, then at the end of the day, they may have injury for the staff, they may delay the client care and increase the use of restricted interventions. Now, nursing professionals are often the first to encounter escalated behaviors, and that is because when there's a problem, they'll call on you, especially if you happen to be within the psychiatric department. They'll call on you that you should come and respond to this child that has what aggression. And so for that matter, preventing and responding to this dignity is very important. And so as professionals, we need to understand that we will meet aggressive cases, but our ability to assess them and prevent the case from progressing whilst also responding effectively is central to ensuring the safety of the patient and yourself, and also the application of therapeutic care for the resurrection of that patient. So you can see in the picture how an aggressive child is looking like. He has expressed his aggression to the maximum capacity you can take of. There's a yelling, there is a fist. I mean, if the whoever he's aggressive at is ready, he will issue him some John Cena blows, and then you could see it. And most of us have seen this. We see this in children, even in the ward. We see them. Children come ill and they become more aggressive. So we say aggressive behavior in children and adults is a symptom rather than a diagnosis. It's a symptom because it is not an end to itself. Okay, something is causing it. Okay, and if that thing is not resolved, then you can be rest assured that that aggression will not stop. Like we look at their frustration. they exhibit some level of frustration. So what is causing that frustration? And then they are responding to unmet needs. So until you meet that need, what happens to that unmet need? Okay. So we say that based on these principles, we have two types of aggressive behavior. So we have the one that is often triggered by the frustration, overstimulation, or unmet needs. And this form is what we call what the reactive or the impulsive aggression. He's reacting to something. Then we have the proactive aggression, the one that the patient does something to achieve something. So, for example, I asked for something and I didn't meet, and I've reacted. The next action I'm going to take may be aggressive in order for you to do for me. For example, if you call me, I won't mind you. So in order for me to mind you, you give me what I want. And that is a proactive aggression. But for the fact that when you don't give me what I want, I will yield and shout at you, it's a reactive. So the two of them are simultaneously occurring at the same time in some cases. And in other cases, they occur what? Individually in a parallel format. So if we look critically, these things are very, very common. So how do they occur? So the early recognition of this warning sign is critical in preventing escalation. And observing cues include the child start pacing around, clench his finger, raises the voice, refusal to follow a direction or instruction, or delinquency or arrogancy. They change in eye contact and become very wild and then uncontrollable. So in this case, you can be rest assured that what your child definitely has reached the stage of aggression. And for that matter, it is a multifactorial what indicator that it's a lot of things that come into play. So due to difficulties in communication, so at that moment, the child cannot communicate very clearly to you what is worrying him or her. He's just keeping it to himself and he's just demonstrating it to you that sure, this is what I'm doing. And then as a result, the child will be what? It will demonstrate to you that no, once you are not doing what I want, let me show you the where what I can also do. So that they'll do as if they are even coming to beat you. And so that is a reactive aggression. But the moment after that, the child sit down, then you call him, could you come and I'll send you, then he doesn't mind you. Oh, could you come and do this and he doesn't mind you. They will say, okay, come and collect this and then do this. And he comes and collect it and does it. That is a proactive what? Aggression, meaning he has used his aggression to achieve a goal. uh But in the event whereby he reacts to it, then that is a reactive aggression. And as professionals, we must know this too because we all do it. In the government, in the public sector, we do it. We go on demonstration, an aggressive behavioral demonstration, in order to achieve our condition of services. And when the government doesn't give, we go on strike. So the strike we go on is a reactive what aggressive behavior. But the demonstration we go to express our condition of service is the proactive what behavior we demonstrate. These are just examples I've given for you to know the two difference between the difference. So as nursing care and management, once aggression occurs, nursing intervention focus on safety and stabilization while preserving the dignity of the child. So most of the time when we have aggressive behavior, especially in some children that have what, aggression, you tend to bundle them or chain them. That is wrong because as a professional, your number one priority is the safety and the dignity of that child. So when you chain and bundle the patient, and what are you trying? You are infringing on the dignity of that child. Okay, but your aim is to stabilize the child, promote his or her safety and your safety, whilst also preserving what the child's dignity. So these triggers can be minimized by making sure that there's environmental adjustment. So when they bring an aggressive child, the first thing is to find a child in an isolated area whereby that child does not need to come into contact with anybody or anything. And therefore, there's a reduced sense of noise because the higher the noise, children get more agitated with excessive noise and higher the light brightness. So we say provide sensory friendly items. So if you put a child in a room whereby there are toys, or as soon as the child is aggressive and just enter a room and see cartoons being displayed on a screen, at that moment the child, no matter the aggression, will calm down because his mind will quickly be triggered to that interest area. So that's why we say provide what sensory friendly items for these children in those rooms. Now, when you do that, you now what look at de-escalate the what the signs. Now remember that in the war zone, disarming your your opponent is your greatest weapon. So in this case, to de-escalate the aggression in that child is our priority. We have to de-escalate it. We have to bring it down. Okay, calm the child down to soberness before you can even take any intervention. Imagine the child is already aggressive, then you go and pick a needle and draw your diazepam to come and inject. The sight of that needle, string and needle alone will increase the aggressiveness of the child. Okay, so to de-escalate, it's a strategy that we use to provide by strengthening communication and active listening skills. And then by so doing, we are helping to prevent a lessened episode of aggression behavior. So when we do that, then at the end of the day, we are including behavioral therapy program for the child as well as the family, because you don't want to discharge the patient to go home and have a relapse of the aggressive behavior. So once you de-escalate, after this escalating, you have to find out the root cause of the aggressiveness and then try to solve it. Is it psychological? Is it home based? Is it anatomical, or it's physiological, or it's psychological? You try to understand what is causing it and then engage the parent in a therapy service that will give them the opportunity to enhance themselves in solving it at home. The target is for them to mirror your interventions at home, so that once it is mirrored at home, there's no need for them to carry this kid back to the facility. So in the process of de-escalating aggression, the techniques include: one, using a calm and measured tone. So you must be calm yourself to be able to handle an aggressive child. Aggression plus aggression will definitely lead to what? Devastated outcome. So for you, the professional, you have to be more calm. And being calm means that you have to make sure that what you do not entertain any threatening body language. The child is aggressive, then you also say, you see my muscles. If you joke, I'll issue you one blow here, you collapse here. The child become more aggressive in self-defense. Or you quickly go and pick a needle, a string, and a needle. If you don't stop what you're doing, I will inject you. The string and needle is already aggressive to that child. So the moment you exhibit this kind of behavior, is disheartening for the child. First of all, you need to have a calming language. Oh, please calm down. What you wanted, they didn't give you. You calm down. Let's see how we can solve it. You wanted this. The child will know that, okay, so you calm down. If you calm down, we'll get you what you want. It's an assurance for the child to calm down and relax, because there's a third party now involved. And his confidence is that you being the third party will ensure that what the parent or whoever is responsible for addressing that aggressiveness by not meeting the need will be met. Then you give the child some space to calm down and offer limited but meaningful choices. So you do not want to sit in the chair or stand by the window. No, allow the child to be of himself. And at the time of recovery, the child will be fine. Then you can now have a mindful, clear, conscious discussion and approach, even in administering care to these children. Okay. And we said that no matter what you do in the escalation, we make sure that you involve the parents of this child. So we say family-centered approach work to improve communication and maintain healthy family dynamics to decrease aggressive behavior in children. And the interest is that why do we encourage family inclusion? To mirror our effective strategies at home. So when they are involved, definitely they'll go home and mirror what we have done. So in the event that whatever behavioral therapy we are using do not work for us, we need to go in for some pharmacological intervention. And this may include stimulants, diazepam and its associated family, antipsychotics. And the nurses must also monitor sedation and respiratory depression and other conditions that may arise as a result of pharmacological management of these children. All right, so let's look at another scenario. So remember, we spoke about aggression being an influential factor of an expression of a. Let's look at one of the input to aggression. We say aggression is not an outcome, but an expression of an outcome. So fear, everybody fears. Everybody has fear. Some people fear money. Some people fear dodo. Everybody have fears. Okay, some people fear exams. Some people fear school. Okay, so everybody has fear. So our children, as they grow, they also fear. Okay, and fear in children can be positive and it can be negative. Okay, depending on what we are looking at in them. So how it is manifested is very important. So fear is a part of normal development in children. So if you have a child who doesn't entertain fear or does not experience fear or anxiety, then there's something wrong with this child, because it's a normal thing the child must experience. And then we say that this can be positive adaptive force when it is teaching the child to be aware of potential dangers. But if in the light of the event of the negativity, whereby it can make the child become timid and irrelevant in society, then fear becomes what? Negative. The fear can be viewed as a special state of what? Biological alarm system, preparing the individual for escape, which is very fundamental because when you get to a zone that you realize that there's danger, you get yourself prepared to work. So according to Rachman, he defined fear as a survival technique, in the sense that he understood that it's a reasoning time that a pervasion of the natural defense mechanism arises from painful reactions or internal conflict. Okay, so at that moment, there's internal conflict between you as to whether to respond or not to respond, as to how you perceive that thing or not, and that will lead to what? The fear that the child will manifest in you to see. Now, we say that exposing children to severe and prolonged fear, what? They develop a higher risk of what? Maladaptation, emotional reaction. So children who easily or are prolongedly exposed to fear become timid. They become afraid of everything in society. So they do not have the self-dependency or self-independency they are supposed to have. They become so timid, and that is not good for their development. So we say that fear that is not addressed can result in functional impairment. Okay, and this functional impairment can also what? Can have detrimental effect on the child's learning, social skills, and social concept development. Because if the child entertains fear in a class, he may decide not to go to school and may decide not to attend that class. Even if he attend that class, he may decide not to participate in that class for fear of whatever he's afraid of in that class. And this will affect his what? His learning capability. The excessive fear can result in debilitating the pathological behavior, whilst including what? Behavioral depression and the emotional what? Disorders. Now, we are only looking at fear because it's one of the factors that can easily lead to aggressive in children. Because the fact that the aggression may not necessarily be you, but it might be a demonstration of frustration, okay, as a result of what? Of fear. So, is it that most common fears are being left alone, okay, in children who are 2 to 6 years, and then falling, and then dark rooms and strange persons. These are common fears that are found in these children. Now, how do we identify fear in children? So there's always an unpleasant feeling of terror, like we've seen in the picture. The child is accommodating that there's something in that room that is trying to catch him or her. Okay, as we've seen. Then there's an urge to cry and hide. Okay, you go and your child is hiding somewhere in the room if it's not a playing mood, but then that should be worrisome. So pounding of heart, tense muscles, dryness of the throat and mouth, nausea feeling, urge to urinate. Now, at least I was saying that it's no more urge to urinate, but sometimes just to urinate. It happens because even in adults, when you are so afraid to some level, you can even pee and urinate and even vomit at the same time. Okay, as I use that example, if they put a gun in your mouth, you can even vomit inside the gun out of fear and pee and urinate and shit on yourself without knowing. Irritability and anger. So remember, I said aggressiveness, anger, weakness, and sense of unreality. Okay, sense of unreality. So how do we manage fear in children? Okay, that one is a question for us to answer, and I want to see the comments in the responses in the comment section. How do we manage fear in children? How do we manage fear in children? If it's just a responsive factor, how do we manage it? All right. So let's look at the last but not the least, temper tantrum. Someone asked me what is the difference between temper tantrum and then aggressiveness. I decided not to respond because I will get to temper tantrum within the spirit of an eye. But let's respond to, as professionals, we all have children in our homes. Okay, how did we respond, or how did we manage fear in them? The child is afraid of something. How did you manage to get your child out of that psychological state? Let me get some responses in the comment coming in. But temper tantrum and aggressiveness are different. Aggressiveness is a response to what? A behavior, an unmet need, frustration. But temper tantrum is a response to self what? Emotional control. The child is struggling to control his emotions. So he's not targeting it at anybody, but he's just bursting it out on him or herself. So when children struggle to express intense emotions like frustration and anger due to their underdeveloped communication and logical reasoning skills, then we talk about temper tantrums. Okay. And this occurs in children who are 18 months to 3 years old due to the development of sense of autonomy. after this stage, most of them are now aggressive. So they take the two forms. Either they take the reactive aggressive mechanism or they take the proactive aggressive mechanism. But children exhibit defiancy and opposition by having temper tantrums. And it is normal part of child development because it leads to what? The identification of what? The person with logical reasoning and emotional control. So everybody has gone through temper tantrums in one way or the other. But the thing is that most of us, we mix them with what? Aggressiveness. But they are not the same. They are two different things altogether. So we say that get in reinforced when parents respond to it by punitive anger. So once you react to it, the child becomes very mad at you again because he doesn't expect that reaction. He rather expects an emotional response from you. So we are saying that recognizing that tantrums are not bad behavior, but rather a cry for help and an opportunity to teach emotional regulation. Caregivers can stay calm, set firm boundaries, okay, and help children learn to identify and manage their feelings. So it's an emotional response, different from aggressive. So it can happen not because you have done anything to the child, but the child inability to comprehend certain things. Okay, but remember that aggressiveness, the child is responding to something, or is reacting for you to give him or her something. But this one is inner reaction. Okay, so we call it the self battle. So you are battling yourself, internal battle. So as caregivers, we need to. And what happens to? So a child can be hungry, he can get temper tantrum, fatigue, lack of sleep, innate personality of children. This is one of the leading factors to temper tantrums in children. Personality, the ineffective parental skills, because we have not been able to help the child to find a balance between emotions and reality in society. Until you do that, you have the problem. Then over pampering, so you over pamper the child, and the child for needed must be met. Okay, and then dysfunctional family or family violence. That one there is a straightforward thing. And school aversion, behaviors in school, situations in school, attitude of teachers and colleague students can lead the child to temper tantrum without necessarily putting the child in what? In an aggressive what? Mood. So as nurses, what do? We have to set a good example for our children. That's why we have to let professionals to understand that they have to set good examples. Okay, parents must set good example. All right. Then we are saying that besides that, spending quality time with your child will help you identify the emotional needs of that child and fill the gap. Have open communication with the child so that he can also have an open communication with you for you to find the gap and fill it. Then have consistency in behavior. So if you say A, let your A be A, that is setting the boundaries clear. Don't tell your kid that set boundaries, and when you the parent, you can't set the boundary. If you tell your child that if you pour this water, I will lash you, and the child pours the water, make sure you lash the child. Don't say, okay, you pour the water and wait for your father to come. He will come and deal with you. What are you trying to say? The child will get to understand that you yourself, you don't respect your boundaries. It's only my father who respects the boundaries. Okay. And he will see the father as someone who doesn't like him. And by virtue of that, emotionally become unstable and will have a tempered behavior towards the father. So parents to ignore child, leave child alone under certain circumstances for the child to figure out certain things by his own and not to engage the child in any form of what discussion at that point. So once child is calm, then you tell the child that the behavior he exhibited is not acceptable in society and in the family. And then by so doing, you harness the child's intellectual abilities to reason, but do not beat or threaten or what frustrate a child who is exhibiting temper tantrum because you feel it's wrong. No, you rather leave that child into what aggressive what behavior, which will not help the child. Now, when you say pampering is a very effective tool in managing fear, if you pamper your child out of fear, you leave the child into temper tantrum behaviors. So take note of that. So it is not a good strategy. I want to see these things so that I can better address them. So to move away the item they are afraid of, very fundamental. You need to identify what is causing the fear and detach it from the child. Okay. If it's a school behavior, that you need to find out from this child exactly what is in the school that is causing that behavior and help the child to overcome that behavior. Okay. Then by reassuring the child and allaying fears by being there for the child. Very sure. Very true. By building confidence in themselves. So how do you build confidence in your child? You have to spend quality time with the child and reassuring the child, okay? Then someone say, gradually introduce the child to what normally cause the fear to reduce it. Yes. So sometimes say you face the problem by the bull or by the no, you have to let the child face the fear of he's afraid of. So growing up, as long as we were those were some of the things that they were doing to us, you face your fear, and then either the fear consumes you or you consume your fear to get your liberation and your liberty. Okay, then you must be very gentle and calm in handling. So the best thing is you must never handle fear with aggression. Okay, fear in children can never be handled with aggression. Okay, so you must never be aggressive. But you do what is that thing? That thing, what will it do to you? And that thing, it doesn't do you anything. And you are just afraid. No, 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 no. It is you that know that it doesn't do anything. But to him or her, it's a different thing. Okay. So for that matter, you must never handle what? But you must also make significant effort to entertain your child in conversation. Okay. Keep the child close to you so that whatever you are doing, the child understand. And that way you can also understand the needs of them. When the children are close to you and they encounter something, they will not be afraid of it. But if they see you with that thing, they will know that okay, if this thing was harmful, my parents will not have it close to them. Okay. All right. So please let's handle fear with caution in our children so that it does not give much of a problem. Do not be agitated by do not let your agitation level handle your fear of your child. All right. What's this time? 10:51. So let me quickly introduce this last slide and then we'll take the few questions. I've seen some hands up. Eunice, I've seen Eunice and up, so I've taken notes. I'll get back to you in some few minutes, okay? All right. But you ask your question before I introduce the IMCI. Eunice, please go ahead, ask your question.
Okay, sir. Thank you very much. Sir, please, my question has to do with the fear. Let's say my child is scared of an ambulance, but the child is a very
scared of what?
An ambulance, like the sound of an ambulance, the siren.
The siren.
Yes, the siren. Then say the child is a very worrisome child. Is it okay for me to always use that to scare the child, for the child to stop whatever he's doing?
Like we'll do to our children. If we joke, I'll let the policeman come and catch you.
So when the child jokes, I'll just say, okay, I'm calling the ambulance. Then the child will stop and then sit quietly. Is it okay, or it's rather aggravating the fear?
Psychologists will say that in every human environment, you should find something you can use to tame somebody.
Yes.
So psychologically, it is acceptable to have such a thing in place because it's a guiding principle for the child. But as the child grows, definitely the child gets to it mustn't be something that will end up having a negative impact. Yes, if your child is afraid of ambulance and then you use that's fine. Ambulance is something that everybody will definitely, even as adults, when you hear of ambulance you are even worried because you know what it means. That is fine. But to say, oh, if you don't stop what you are doing, I will send you to school. You must never use school. So you must never use a positive distance to threaten your child or to make your child become fearful. No. If you say if you joke, I'll send you to school, the child develop the mindset that school is bad. Okay. But if you say, oh, if you joke, I'll let the policeman come and catch you, then he knows that police people catch bad people. So that means what I'm doing is bad, and I'll go to prison, and prison is a bad place. So the point is that you can identify what you use to control your child, the fear. But it might be a negative one. So that when the child grows up and realizes that it's a negative one, it doesn't still influences that mindset. You know, you grow up and say, that's a crime. My mother used to say that you would send me to school. No, the school was good for me. It will not be good. I don't know whether you are clear with my point.
Yes, please, sir, I'm clear. Thank you.
Any other question? All right. So I go ahead to introduce the IMCI for us. And Khadija, yes, Khadija, ask your question. Yes, Khadija.
Sir, please, good morning.
Good morning, my dear.
Sir, please, my child is not with me. He's 3 years. But when I realized, when I went there, before he will go to school, he will say, oh, he doesn't even want to be with the caretaker. He said he wants to go to school. But later on, if you send him to the classroom, he doesn't even want to enter. He will say, oh, Pupu, if you send him out, I will. So he was doing that. So later I went to the teachers and asked them, now why? The boy used to come to school. If you even ask him not to come, he will cry. But now the boy doesn't even want to sit inside. I was worried. Even now, I'm still worried about it.
So for children and school, a lot of factors come into play. And then from the psychology perspective, they always say, well, there is a causal factor at where he's rejecting. Everybody will not reject a place when that place is positive for you. You only reject a place when there's a negative outcome from it. So definitely there's something in that school that the child doesn't like. It can be positive thing he doesn't like, or it can be negative thing. You still have to still investigate. Let the teacher, you have to do this with the class teacher. He has to put a key eye to identify. A colleague could be a bully. One, a colleague could be a bully to the student. Or two, the teacher herself or himself could be a bully to the student, to him. Three, it could be that he doesn't comprehend what is happening in the class. What they are teaching, at the end of the day, he doesn't comprehend. So he's always lost. And by so being lost, he feels that it's a waste of time for him. Four, the environment itself, Kasa, you have to find out, is he okay with that environment? Because children will react to where they don't want to because of it, the outcome of it or the impact of it. So if it's rejecting school, this is why you need to work with the tutors and try to find. You can also do your own investigation with other colleagues of the child. Try to find out from some of his colleagues when he comes to school or she comes to school, what does he do? What happens in the class? That kind of children, as innocent as they are, they will talk, and then you get to understand what is preventing this young little one from not going. Also, ideally, it gets to some time that we don't want to go to school. It does happen. For no apparent reason, you just don't want to go to school. You have enjoyed home freedom. You are in school, remember that there is rules and regulation. Okay, you are limited. You go and play small on 15 minutes, they say come back to class and learn. At home, there is freedom. You are playing all 247 if you can. So sometimes those things too are also. So at some age, some children do not want to go to school because of what? Those opportunities on them. Also find out what is at home. That is so much key interest to this little one that he wants to spend most of his time there doing that he doesn't want to do. Sometimes the cartoons in their house, they're playing games and still things we make available for them in the house sometimes make it very difficult for them to not want to go to school. Let me introduce IMCI and then we'll go because the other class we finish IMCI. So if I don't introduce it to you, then you'll be lacking behind what IMCI is. So we are saying that children as they grow, they have these issues, and these issues come up. And when a child is active, and depending on his active level, he can easily be identified to either be ill or not by either refusing to eat, by unwilling to play, by crying to be carried, and having difficulty in sleeping, disinterest in toys. These are signs that children who are very active exhibit, that you, a parent or a professional, you should see and know that what the child is not feeling well. So we say the common illness of childhood causes one or more symptoms. And by observing these symptoms that I've just mentioned, one can judge that the child is either not doing well or is in a severe state. So in order for us to have a clear understanding why IMCI came into place, it is as a result of the global causes of under 5 mortality rate, whereby we had about 5.9 million children who were less than 5 years dying in 2015. Okay, and this is very significant because we could see pneumonia, birth asphyxia, diarrhea, and malaria contributing to this, with about 4 to 5% also being associated with malaria and malnutrition, showing that what breastfeeding, complementary feeding are very key in what in preventing, because the whole immune system of the child depend on the what his feeding practice. So children present this multiple potential dreaded conditions at once, and then most of our facility we don't have diagnostic tools. And because we don't have diagnostic tools, we are compelled to manage these children based on the signs and symptoms these parents present. And sometimes we need to refer to another level. So in order to avert this struggle and create standardization, the WHO and then the UNICEF in 1995 developed a strategy known as the IMCI, which is a case management for most common childhood problems, especially most causes of death: pneumonia, malaria, tetanus, measles, meningitis, those conditions. And the policy is that the integrated management targets a standardized protocol. Okay, the case approach offers simple and effective methods to comprehensively prevent and manage causes of what serious conditions. And this protocol also gives us the opportunity to not only manage a child based on the signs and symptoms they present, but also to assess for other disease conditions that the child may be suffering from, which the parent or the caregiver may not know and may not tell them. So the whole IMCA process can be used by every healthcare professional at the facility level, either a health center, a CHIP compound, or at any outpatient department. Now, but the guidelines describe how to care for a child who is brought to the clinic with a particular illness, and then how you will schedule the child. So in caring for the child, we are looking at the 7 outline. They are assessing the child, classifying, identifying treatment, giving treatment, follow counseling, and doing follow up. So these are the basic principles that surround the IMCI process. But it has its main components, and the components are: one, to improve health worker skills. And how does it do that? It improves it by giving you a standard case management protocol that you follow. So that if you are in Zorungu and you meet a case and you arrive that that case is malaria, and I'm in Tatale and I manage and arrive that my case is malaria, then our case management protocol will be the same because we are all using the same standard. So it creates a standard arrival of a condition across board, irrespective of the location. So by so doing, it improves you, the health worker, your ability not to rely on your cognitive recognition skills, but to rely on a standard process, so that you do not miss a gap in assessing this child. Then it also improves the health system by making available IMCI drugs within the facility level. Okay, and then the end benefit is for the patient and the family. So it does improve community and family health outcome system by promoting good nutrition and then promoting home-based care. So these are the three components of IMCI system or guideline protocol. That it will improve the health worker skills, it will improve the health system, and it will improve the family and community practice for the health and development of the child. So I made mention of the steps or the procedures involved in implementing IMCI protocol. And I said the first one is to assess the child for danger signs. Beyond the signs and symptoms the parents will present and say to you, you have to check for danger signs. And these danger signs could possibly be bacterial infection in young infants. So you ask questions about common conditions, examining the child, checking nutrition, and immunizing the child's status as well, immunization status of the child being checked. So you must check all this. It's a guideline, and in that guideline, they stipulate what you should look out for in terms of danger signs. Then we say classify a child's illness. So based on your assessment, you now classify the child in either the child needs immediate referral, which is a red category. It's a condition you can manage within your facility by giving oral medication, or it's a condition that do not need medication but rather need home-based care. So you classify that condition, and after classifying, you identify the specific treatment that the child requires at that particular stage. So if the child is in category red, that means instantly you give first aid before you refer. So we say, if the child requires referral, give essential treatment before the patient is referred. Do not just sit down and write a referral for the patient to go away. No, because in some settings where I work and come from, sometimes you can write referral for a patient and to take the patient 2 to 3 days before the patient will even go to the referral facility. So if you do not give a first aid to keep the child alive, then at the end of the day, that child will go back unattended. Then we say that if the child does not need referral, in your facility, give the first dose of the medication under observation. So once you identify the drugs, you treat the child. And when you treat the child, you have to inspect that the child is given the first dose right in front of you to ensure the initiation of treatment. So we say provide practical treatment instruction, including teaching the caregiver how to give the oral drugs, how to feed and give fluid during illness, and how to treat local infections at home. So in the guideline, all these steps are there. So in the guideline, it will tell you what messages you should give in terms of oral drugs, what message you should give to the caregiver in terms of feeding them, fluid management, and then how to treat some. But you will also be required to counsel the mother on appropriate feeding practices and then to avert other negative feeding outcomes such as malnutrition. So you have to counsel the mother about her own health to also feed and take care of herself. So workers also teaches the mother how to recognize signs indicating that the child should be brought back to the clinic immediately. That's the follow-up. So when indicated, a healthcare provider assess feeding, including breastfeeding practices, and provide counseling to solve any feeding problem. So if you assess the breastfeeding practice and realize that the mother has attachment problem, it is prudent on you, the health worker, to make sure that what the mother understand how to properly position and attach the child. So this is a summary of the concept, the rationale, and how the IMCI protocol is rolled out. So for every sick child that is up to from 1 to 5 years brought to your facility, you must first assess the child. And even as part of assessing, you have to categorize the age of this child. Then you classify the child illness using the color code. Then if the child needs agent referral, the protocol still says that if agent referral is needed and possible, identify agent pre-referral treatment needed for the child classification. So before you refer, you have to give pre-referral treatment. Then treat the child, give agent pre-referral treatment needed. Then refer the child. So you have to explain to the child's caregiver the need for referral. Calm the caregiver fears and help resolve any problem. Then you write the referral note. You don't just write a referral note and say, okay, because of your child condition, take the child to this place. No, you have to reassure the caregiver that you are referring because you do not have ABCD to manage the child, and not because the child condition is bad. So that the mother can have confidence. If not, if you let the mother have the person that the child condition is bad, they'll go and sit home and wait for the child to die and then that kind of stuff. Then the other thing that you need to also make sure what if there's no referral required, then identify the treatment that the child needs for his specific age and weight, and then treat the child, giving the first dose of oral drugs in the clinic, and then advise the child caregiver and teach the caregiver how to give those oral drugs and how to treat local infection at home if there's a need, and give immunization where you see an immunization gap in that child. Rabiatu, can you mute yourself? Then counsel the mother also. So you assess the child feeding conditions I've made mention, and based on that, you counsel. Then you do the last is to follow up. So give a follow-up care when the child should return to the clinic, or you, the health professional, will follow up to the child's home to see what is happening at the home of this child. So when you do that, then you can be sure of what? Achieving the target. So I think I will stop here. Then when we meet next week, we'll look at the charts that are being used. And then, so if you want to assess the child, which charts do you use? What are the indicators you are looking for? If you want to classify the child, how do you classify? What are the classifications of these children? And what are the pre-referral conditions that must be met? Thank you for your time. And then you may ask a question. We have some few minutes. We just have some 8 minutes. And then I have to prepare for the next class too as well. Right after this, I'll be meeting the A group. So is there any question? And then we can look at the question. And then I will go. Someone is asking from tantrums. I've explained tantrums to the highest bit of it. Hey, African parents, it's we now are making our children what they are. So tantrums, I said there's a difference between tantrums, temper tantrums, and aggression. And I said that yes, the difference between them has to do with the extremes of the anger, okay, the range, and then the what happens. So aggressive is which is a general response to an activity that you, the parent, might have done to the child, or in response to the child wanting something from you, the parent. But tantrums is an emotional response of the child to his or her own emotions. Okay, so it is one has a trigger, external trigger, and one is more of an internal trigger. It does it. If not, to some extent, their characteristics are almost intertwining. Okay, and tantrum mostly is at the early stages of the child between 3 and 18 months. But after that, aggressiveness goes beyond the child age of 3 years. All right. Is that all? Any other question? Please, is anybody having a question? Yes, Imaya. Imaya, unmute yourself and talk.
Hello, sir.
Yes.
Sir, please, my own is not a question, but it's just a suggestion to the sister who was complaining of how the child doesn't want to sit in school.
Okay.
I just want to tell her that maybe anytime she sends the child, she can just pay unexpected visit to the child.
Correct.
To see how whether is just the morning the child doesn't want to go to the school, or maybe there is something disturbing the child. If it is just the attendance, if the mother leaves, the child will be happy. But if it is something worrying the child, if she goes, she'll be able to find out.
All right. That's very true.
Thank you
That's
very much.
true. That's very true. Yes. So my dear Khadija, you have to visit your child's school unannounced and unexpected, and go with a gift for your child. Okay. When you do that, you motivate the child to learn. That's fine. Now, thank you, Imaya. Appreciate it. Any other comment? Yes, Florence. Mami Flo.
Sir, hello, sir.
Yes, I can hear you.
I have a 4 year child. When I send her to school, the teachers have been complaining that she doesn't
Then he doesn't
talk in class. When the teachers are teaching, the colleagues will be raising their hands to talk, and she doesn't talk in class. The teacher will talk to her, and she will not mind them. But when she comes to the house, she will be talking, playing around. But in the classroom, she doesn't talk.
So have you found out from the teacher what happens in class? Remember that intimidation and fear can set that child back. But if the child has ever spoken and was ever shut down on, or have seen the teacher shutting down on colleagues, for example, if I'm in my class with you and you speak and I shut you down, embarrass you, that me, I will not, if I'm also another student, I won't do it. Okay, that's one.
It's like the third school now. The 3 schools all that I sent her, that's what the teachers have been complaining about.
So maybe
her.
that's also his nature, because even me, I even ask in your class currently, there are people in your class, they will never speak. But that doesn't mean they do not comprehend what is going on. So there are children who are naturally like that. Remember when we started with the lecture and we look at group, we look at the individuality of the individual. Every child is unique, and every child is different from every child. So that is the uniqueness of it. Outside, he's active because he finds himself among his peers and find that environment conducive and appropriate for him to express himself. Inside the class, he may have a different mindset that the class is a place for learning and may not want to expose certain weak lines. That is the uniqueness of the child. So if it was that the child was dormant, inactive in class, inactive at home, inactive anywhere, then that one is a problem for you to investigate. But why is just that it may not be inactive per se, but that is also his style. And I had a lot of, some of us I'm a victim of one. I'm not a type that could just be talking in class. No, until my teacher calls me, more now answer, then I'll speak.
Okay.
But to raise my hand and also ask a question or answer a question, I won't. But right after the class, I'll go ask some of my colleagues that question that I would have asked the teacher. And because I understand better when my colleague explains to me than when my teachers or a lecturer used to explain to me. So that is the principle that we have. So we have that uniqueness of the individual, who and it's for you to also identify it and help the child harness on it. So you have to engage the child yourself in home-based learning. And from there, you try, Freda, can you off your video? From there, you try to let the child also contribute. So the contribution starts from home. Okay. So when you have classes with the child, then the child will also get the opportunity to participate.
Thank you, sir.
Flo, are you okay?
Yes, sir. Thank you.
Yes. All right. Any other? Charity.
Sir, please can inferiority complex be associated with fear and can still be
Please come again.
hereditary? I said, can inferiority complex be
What
associated
confidence?
with inferiority?
Okay, inferiority complex. Okay.
Yes. Can it be associated with fear? And can it be hereditary or the nature can also influence that? Thank you.
Inferiority complex is it's a grow up attitude. Okay. It can be attributed to a lot of factors, even from the home environment, how you were brought up at your home. Okay. So for you to attribute it to genetic, yes, some people grow up from a family whereby they are naturally timid in a way, they are not vocal. So for not being vocal, fine. But to be inferior, to have that complexity in you, meaning that there's a trigger, something must have first of all kept you in that place. As a man, Charity, can you off your video? Something might have kept you in that position before you get to that complex. It's if you look at the cycle of inferiority complex, it's not a one-time event. Okay, it's a process, and with that process, a lot of things happen before the child arrives at that stage. So yes, you can help your child come out of it. It's come outable. A child can come out of them complex by you helping the child build confidence. You see, most of the time, inferiority complex is coming with fear because it's an intimidation. So building the child confidence, not shouting on the child, not abusing the child with wrong utterances or wrong action, build the confidence of the child. If the child speaks today and what the child says is wrong, and you find a loving way of correcting the child instead of abusive or fearful way of correcting, then the child will definitely become confident. But when you do otherwise, then at the end of the day, you can be sure that what you will not have a child that will be confident with him or herself. I don't know whether you are okay. You understand my explanation.
Yes,
Charity,
please.
are you okay?
Yes, please, sir.
All right.
Thank you.
Thank you. So please, as we go, let's understand that what these behaviors are age bound, and once the child does not cross the age, it is not a problem. Once he crosses the age and become a problem disorder, then we can be worried. But before the child even gets to the age, we have understood how to help these children to prepare themselves to come out of it before they even get to that age. A child can be 2 years old and can still not do, will still be able to do bladder control based on how we treat them, how we train them. So let's help our mothers to understand this and alleviate the stress and then the worries that come with this problem, a behavioral problem in children. And that will make our work more easier, more blissful, and more useful to our mothers. Thank you. Have a blessed week and enjoy your work.
Thank you, sir.
Thank you, sir.
Thank you, sir. Same.
Thank you, sir.
Bye.
Thank you, sir. Bye-bye. Sir. Thank you, sir.
Baraka, sir.